Dear colleagues, I'm Filippo Crea, Editor-in-Chief of the European Heart Journal. Welcome to our monthly dialogue. As you know, this is a Socratic dialogue among editors, authors, reviewers, and readers. It is live streamed and it is free. And please ask questions. We will be happy to address your question. Our guest today is a legend in the field of heart failure, Professor Marc Pfeffer from Boston. Thank you, Marc, for accepting our invitation. And our hosts today are two editors of the weekly journal Scan, Giovanna Liuzzo and Massimo Volpe. As you know, the weekly journal Scan is a window we have opened in the European Heart Journal on the most important paper published every week in an important journal of general medicine in the field of cardiovascular medicine. This important paper is summarized in the weekly journal Scan and is accompanied by an editorial comment. Now, Giovanna and Massimo have recently published a contribution in the weekly journal Scan on an important trial, the Paradise MI, published by Professor Pfeffer in the New England Journal of Medicine in November 2021. Well, today, Massimo and Giovanna, after publishing the weekly journal Scan on this important paper, will discuss Paradise MI with Marc. But today is a very rich day because we also have another important guest who is Pardip Jean from Glasgow. And not only is an important cardiologist, but is also one of our top reviewers. And we are always grateful for the remarkable job made by our wonderful reviewers. And Pardip is really one of our top reviewers. Well, I've spoken already too much. Massimo, please, can you introduce Marc, and then we will start a nice discussion on Paradise MI.
Well, thank you very much, Filippo. It's a privilege for me to be here today to represent the team of the weekly journal Scan, and also Carlo Patrono and Leda Galiuto are part of this team, and to lead this dialogue today. And it's also a privilege to introduce Dr. Marc Pfeffer. It's very, difficult for me to summarize Dr. Pfeffer activity, but currently is a distinguished Dzau Professor of Medicine at the Harvard Medical School and senior physician in the cardiovascular division at the Brigham and Women Hospital in Boston. If we have to pick one specific aspect in the scientific career, and with enormous contribution to medicine and cardiology of Dr. Pfeffer, he is the man who, together with Janice Pfeffer and Jean Braunwald, identified the role of ACE inhibitors in be able to revert the damage in heart failure done by the progression of ventricular remodeling. This was following myocardial infarction, but also Dr. Pfeffer was the man who described the importance of ACE inhibitors in left ventricular dysfunction in the early stage and in the late stage, and had the principal role in many, many trials. In fact, is reported to be the most highly cited cardiologist today by the Science Watch, and has taken many awards from all the societies, including the gold medalist of European Society of Cardiology, but also the American Heart Association and the American College of Cardiology, and is a distinguished doctorate and laureate of many universities, especially in Europe. So I'm very glad to introduce today Marc Pfeffer. And can you, Marc, just for our colleagues, summarize what you think are the principal message of the Paradise MI, which we could try to comment on the European Heart Journal, and it's a very interesting work. So please, Marc.
So I start by thanking you for that wonderful introduction. And I think Paradise MI has its roots in that introduction. The field of treating post-MI, since this is dialogue, Maximo, I'm going to do dialogue.
No, yeah.
I think it's the MI that brought cardiology together as a specialty. Now, we're so many different ways to go and so many subspecialties, but it was the coronary care unit that brought people together. And it was the coronary care unit that brought cardiology research together. And the accomplishments there have been fantastic, from Desmond Julian to defibrillating. But to move the field forward, we had to recognize what the problem was. And I think it became clear that not all infarcts are created equal, and infarct size. And you mentioned my late wife, and you mentioned Eugene Braunwald. So I can't have a discussion without saying that every coronary care unit, every hospital around the globe is working to save myocytes. And that's something we didn't know. But then it was proven there are things we could do. When I first came to work with Professor Braunwald, that was so clear that was a path. My late wife and I tried to pick a different path. You could salvage myocytes, yes, but what happens after you leave the hospital? You've had an infarct. It could be a big one, it could be a little one. What else happens? And that's the remodeling process. And you mentioned that, so I'll just build on it to say that Paradise MI was our dream to beat what we did 20, 30 years ago. I had several attempts to beat. So ACE inhibitors beat placebo for sure. And then the world got into that with GISI, ISIS, the TRACE investigators. ACE inhibitors are there. They've earned their place. When ARBs came out, we saw an opportunity beat an ACE inhibitor. And we tried. Valiant, 15,000 people randomized to the ACE inhibitor that won versus a new kid, valsartan, or the combination. And what we learned was, no, you must inhibit the neurohumoral system, an ACE or an ARB, but not both. Quite a lesson. And then I saw the ARNI come out, and I was not part of the studies that showed the wonderful benefit in paradigm in heart failure. It made me jealous not to be part of that. They beat an ACE inhibitor used at the right dose in the right patients. So being jealous, I was motivated. Please let us try this post-MI. And it took years for that please to be translated into okay. And the okay was Paradise MI. And now we had a choice. We believe, based on paradigm, that the ARNI, the combination of an angiotensin receptor blocker, exactly the one we used in Valiant, plus a neprilysin inhibitor, sacubitril, we believe it's better than an ACE inhibitor. Then we chose the ACE inhibitor. We chose ramipril. Why? Very impressed with Dr. Yusuf's work at ramipril has something extra special. Vascular disease, the imprint on vascular disease, plus it was proven post-MI. So it's a long answer, but it sets us up that we didn't go against placebo. We went against what was proven to be best. And in addition, I will also add, and please, treating doctor, do everything you can to minimize this person's risk. So it's pretty an interesting story, and it goes to, and actually it shows in 30 years, improvements, improvements, improvements. Not one drug, not just statins, not just revascularization, but everything put together. And this is where I love cardiology. The bar is that high. Don't tell me you have something good. Tell me you have something better. So we launched Paradise MI. Is it better? You set up your bar. This is the definition of better. CEC reported. Now, Pardeep is on the line here. He worked in our CEC, and he does a lot of this. Clinical Endpoint Committee, not just the investigator. And what would we look at? CV death and heart failure. Was it reduced? Numerically, 10% lower. Statistically, not significant. So that's the bottom line for the first-year fellows and the residents. Oh, sorry, didn't make it. But there are many other things. We gave this drug in the midst of an acute MI, on average 4 days, to people who did not have a run-in, and we had a safety profile against a proven drug. So there's a lot to talk about. I'll just say we didn't make the primary, and leave it for you to ask me more about what else we are and where we're going.
Well, the first question that I have for you is that you had a much lower number of events compared to the former studies.
Yes.
And the way you designed the study was probably expecting more events, and that could be could have been a surprise on one side. On the other side could be one of the explanations why maybe the sample
Yes.
had different. So can you comment on this?
Yes. First of all, when I presented this for the first time, of course, I have an executive committee and everybody looks at the slides. And my last slide showed what you and I have just been talking about, the death rates after a high-risk MI from SAVE to Valiant to Paradise. And it didn't talk about therapy, it just talked about death rates. And it was dramatically reduced. So the event rates were down. We knew that things are better. We didn't know how much things are better. Right. But as an insurance policy in trial design, we made the trial event-driven, which when people read trials, when they see those two words, it means the hypothesis as described is going to be tested. So we were event-driven. So I can't say we didn't, it was understudied. However, obviously, if we had more events, and we did when we looked at investigator reported, it was significant. So this is a lesson. I have many lessons, but this is a lesson that even event-driven, you should be a little more humble, and that's a humility factor of any trial. I think we were right. I think the concept is right. I think we certainly demonstrated it's as safe as an ACE inhibitor. And I think we showed every time we looked at it, there were fewer events with the ARNI than the ACE inhibitor. But we couldn't be definitive. I think if you allow me, another mistake, not a mistake, but another thing, if we could do it over again, investigator reported really is, now that we're in the 2022, when people look at epidemiology, when they look at conducting new trials, that's what people are using. Obviously, if the committee said, no, we're not taking this as a hospitalization for heart failure, but that human being was admitted for heart failure, and you then count hospitalization for heart failure, there it is. So I now think that is the way to go. Go with the medical records And I also think once you have heart failure, that pendulum of recurrent events comes in again and again. And that was very definitive when we looked at recurrent events. So the one thing I need to emphasize that I didn't, in the design of this trial, with a drug that was already proven to be effective in heart failure, we took all those patients out. So any patient who had heart failure was not eligible. So I hope that answers your question, but the trials are really alive. Time impacts a trial.
Absolutely. Well, Giovanna is one of our, scanners, and she definitely has a question for you.
Yeah, going ahead with this discussion, I would like to ask two things. One, actually, I was pretty impressed by the fact that looking at the recurrence of events, definitely there was a significance in the ARNI arm. I think that is important, as you were just saying before, because one of the major problems with these patients is that they become frequent flyers, so-called. So this is an important part of the story. Even if just we reduce the recurrence of this patient to the hospital is I think, a goal that is good enough. But my question is regarding the primary outcome. There is a problem, I think, in the design. I don't think you can do nothing different, but maybe it may represent a problem. In the arm with the ARNI, there was a discontinuation of previous ACE inhibitors 36 hours before randomization for safety problems, of course. But in the other arm, with the ramipril, ramipril was given until randomization. I think that 36 hours in this particular setting may be important. What do you think?
Well, I'm going to do that first, your second question first, and then I'm going to do recurrent. And maybe it didn't come across, but I think my team, and this is a whole group, did a better job than you think on this aspect, the first 36 hours. So the first 36 hours was important because of the threat, the fear of angioedema in someone who was on an ACE inhibitor. So if you were on an ACE inhibitor, it was stopped. And then we had this 36-hour period. But of course, if you were getting ramipril and not sacubitril valsartan, it was less of a threat. And we, being ethically and very attuned to the person's risk, wanted them not to have a break. So the ramipril group continued. But I think what was not clear, what we did was we bridged someone who was randomized to sacubitril valsartan, didn't get sacubitril valsartan immediately, but they got ramipril. So the packaging of the drugs was so clever that if we knew you were, we protected everybody. So you either got just the ACE inhibitor or you got just valsartan, which is very effective by itself. So I think we covered that aspect of the design. And that took a lot of planning and how you keep the blind and how you do it. So we were aware of that, and I do think we addressed it. Now, recurrent events. I will take some blame for that. It's clearly there. I mean, whether you use the investigator reported or the CEC definition of an event, both reduced by about 20%, and with large numbers, both highly significant. So that's a clear and true message, robust. Why didn't we make that more of a primary endpoint? Recall, this drug's approved for heart failure. So the last thing we wanted to do was say, now that the patient has joined the heart failure club by having this admission, don't give this other drug. So we didn't pre-specify recurrent as our primary because we thought around the world, once somebody had an admission for heart failure, real classical heart failure, they would get the drug. It turns out because of economics, because of regulatory approval around the world, it didn't happen. Less than 10% did. So if I knew that when we were designing the trial, I would have said, let's go with recurrent. But that's the reason we didn't. But that's also the reason that we're able to show such a big difference. People didn't jump to sacubitril valsartan as they should. And I think that's the biggest message that came out of this trial. If you are waiting for someone, while you're waiting, they have a risk of sudden death. While you're waiting, they have a risk for another event. So showing the safety, showing the tolerability, I think should lower people's barriers to start this drug in people with heart failure.
So thank you very much.
Just housekeeping. I would like to invite our colleagues to ask questions via the chat box. Please ask questions, and Professor Pfeffer will address your questions. Please do it.
Yes, please ask questions also, because today we have a special privilege because the editor-in-chief will pick up the best questions and ask them for you to Marc. Well, Pardeep, thank you very much for being with us today. Actually, you could be one of the next guest of the dialogues in the future, and you're contributing so much to the journal and to the progress in cardiology. And it's really nice to have you here today. I'm sure you have a question for Marc, and so I'll switch.
Yeah,
to
sure.
you.
Well, thank you again for the invitation, Massimo. I'm not sure I'm anywhere near the stature of Marc to be invited to do this, but thank you. I mean, I guess maybe I could ask you a question, Marc, that I think a lot of my colleagues who are clinical colleagues who are not trialists or not really academics in a sense often ask me about Paradise MI, that you might be able to offer some insights, because I know you'll have looked at the data in many, many different ways if I know you well enough. I mean, one of the issues that the myocardial infarctions these days really kind of split into two camps almost, don't they? You have the ST elevation myocardial infarction, and then you have the non-ST elevation myocardial infarction. And many people would say they're different things. They're different beasts almost that have different prognosis. And maybe actually had you stuck to the more severe type of ST elevation myocardial infarction, you might have seen something. Maybe these small non-ST elevation myocardial infarctions diluted your sample. Maybe you could tell us about your thoughts on that in the trial design, including these non-ST elevation myocardial infarctions.
Sure, but first I have to build on what Filippo was saying about you being a reviewer par excellence. So I've had many opportunities to write papers with Pardeep. So you get Pardeep's review internally before you send it to a journal. That's pretty amazing. Okay. Yes, types of, we could do subgroups. We could pick your favorite subgroup, my favorite subgroup, but it all boils down to the same 10% reduction. It also all boils down to a 19% reduction in recurrent events. So I can't change that. I can say that this trivial non-ST elevation infarct is a big deal. It's a very big deal because we chose those that are associated with either reduced EF, which probably means they had a heart attack before, or pulmonary congestion, which probably means they had a lot of comorbidity. And indeed, they don't do well. If you pick this non-ST elevation infarct with these other factors, they don't do well, meaning they're older, they've had more comorbidities. Now, the effective therapy, since you are on the line, Pardeep, and you would slap my hand if I said something. The test for interaction was not significant. So I can't go to my colleagues and say, sacubitril valsartan relative to ramipril behaves differently. I will, and our team and others will write this paper, will do exactly what you're asked about. And there are some interesting differences there. But I think for the general practicing cardiologist, I have to say, in the absence of a highly significant interaction, this effect we found that Giovanna likes for recurrent, I like for recurrent, is homogeneous across the distribution. But there are very interesting differences.
Massimo's in.
I have a question. Massimo, can I ask a question?
Absolutely.
From Johan Bauersachs, who is our deputy editor for heart failure. And the question is, Mark, maybe the randomization was too early. We rather often see patients that recover ejection fraction during the first days after distribution due to stunning or other things.
Yeah.
So randomization after 5 days might have been preferable.
Yes.
What about this suggestion?
Yeah, it's a different question, but a very important question. And I do think it's one that we wrestled with. Ejection fraction, especially people who, and by the way, 80, almost 80, high 80, almost 90% had coronary intervention before randomization, not just stents and the newest and greatest drug-eluting stent, newest and greatest anti-platelet agents. So yes, and you would expect the ejection fraction to improve in most patients. Actually, that is the case. So if we then waited and said, let's really just take those whose EF is down, we might have had different results. Yes, that's a fair question. And I have to say, my right arm, Scott Solomon, kept asking that question every day before we started. But the ejection fraction is going to change. It's going to change. How do you use that? And I couldn't figure out a way of randomizing someone, repeating their EF, getting it in time. So you're in good company. You and Scott can both bother me for the rest of my life. Yes, maybe you're right. And maybe we need to let the clock start, let somebody have their damage. But on the other hand, when you're trying to influence post-MI, many events happen early. I learned that from GISI and ISIS in my early career. Charlie Hennekins and I were going to do a study on timing of remodeling called HEART. Take people day 1, take people day 14, and we were randomizing people for an echo study. And what happened, ISIS and GISI got together, ISIS 4, GISI, I don't know what the number was, and looked at their ACE inhibitor work and said, we're saving lives in the first 2 days. So how could we hold a therapy when it's saving lives in the first couple of days? So we had the two hands, and obviously the compromise, you now have the results.
Okay, so
Massimo, I have a quick comment from Johan, and then you will continue. The comment is quite nice because he's suggesting you, Mark, to write an editorial in the New England about what is the truth, the evidence behind the scene, what we are saying today. This, I think, is an excellent suggestion, but I suggest you to write for us.
Yeah, no, it would be for you because here we are. This is the platform. We're discussing this. But I will tell you, it takes many years for the dust to settle. There are people that don't agree with some of the things I'm saying, some that did. The best example is Top Cat. My own committee couldn't agree on what to say day 1, but now the dust is settled. And we have an article which defines all that, not in New England, but the New England evidence, where we were able to give the whole story. So yes, Filippo, I'm taking this as an invitation.
Absolutely.
Yeah.
Yes, it'll be fun.
Yes, there's a question from John Cleland.
I don't do questions from John Cleland.
Okay, so let's go ahead. Yeah. Okay. He says, looking at the subgroup analysis, it looks like the higher the risk, the greater the effect on the primary outcome.
I will take that from John Cleland, because John, you're wrong. Actually, that was we thought, oh boy, if we could only, you had to have 7 additional risk factors. So we were positioned to do exactly what Dr. Cleland is asking. And of course, we were hoping that he was right. For me to hope he was right, imagine that. So I was hoping you were right, John, but we weren't able to show that when you pile on more risk factors, and the way to prove that is the person's event rates increased, that group's event rates, we weren't able to show that there was a distinguished benefit in the high end, not the low end. So that, sorry. In one way, I'm sorry that we didn't show it. The other way, I'm not sorry. But that's the fact. We did look at that carefully, and we'll continue to look at that.
Massimo, I have a strong temptation now. Mark, being John Cleland with us, what is your opinion about the universal definition of heart failure? We published a nice debate, pro and contra, with you and John. Any developments on this universal definition? What are your feelings? The same as the paper you wrote for us, or you're changing your mind?
Why would I change my mind? I left it by saying, John, go get the evidence that treating people based on their natriuretic peptide and forgetting signs and symptoms makes them better. So, and John will do that. I mean, he's dedicated to get that evidence. So, but the editorial was written now, and I'm saying, please don't do that now, but go get the evidence.
Yeah. Interesting notion, but we need the evidence. This
Thank
is
you.
the bottom line.
Oh, thank you for taking my side.
Well, together with Pardeep, we were discussing about the effect on ventricular function in your study, but maybe Pardeep can ask you.
Yeah, sure. I mean, obviously, we've talked a lot about events and outcomes, which are crucially important, Mark, and no one would deny that. But maybe you could take us full circle to what happened to the ventricle, because obviously that's where your story began in all of this. And
right.
Do you have any information on what happened to the ventricles of these patients during the trial?
Well, wouldn't you like the atria too, Pardeep?
Yes, please tell us about the whole heart.
Okay, so to launch a trial like this is 5,000 patients. We saw it as an opportunity to do this question that Massimo asked about, that you asked about, that got us into this on remodeling. And Emil Shah, who leads our group and really did this all independently, put together a team sub-project within Paradise MI, and we had 450 some odd patients, and in a blinded fashion. And Emil is a very careful worker. He blinded not just for therapy, but he blinded his group and himself. Am I looking at the first echo or the second? So I point that out to people, because often you see, oh, it's blinded. But if everybody knows these are the seconds, you have a tendency to let them get a little larger. So he did it very well. It's another story on endpoints. So he chose LVEF and left atrial size as the primary endpoints. And again, we're against ramipril. We're not against placebo. Mm-hmm. And so he's presented this, and he's written a manuscript on it. So it's not my work. It's Emil Shah's and the team. Bela Merkeli and his group in Hungary, major contributors. But this is echo, and with the plus minus, not able to show that. But interesting, end diastolic volume was reduced more in those on sacubitril valsartan. Now I say that because that's consistent with some other work with sacubitril valsartan in heart failure. So Maximo, it gets to numbers again. We had 400. If we had 800, I would be telling you remodeling. But now I can say every index looked better and end diastolic volume was better. So the hint is certainly there that we are getting a little better. Adverse remodeling is less with the ARNI than a proven ACE inhibitor. But it's, again, the same story. It's hard to show that with the primaries.
So on the basis of what you're saying, you think there's still room to think to use sacubitril valsartan in this with this indication in the future at some point?
Well, to say that with the definitiveness you just did, I'm not a regulatory, this is the beauty. You do the clinical trials. You don't make the guidelines. I think, it's kind of, I know the bar that people have. I don't think we made that bar, but if a patient's in front of you and economics are not an issue, I think we've given some answers here. And should this drug have been earlier in its time course and more resources for research, or another ARNI comes along, I might take Johannes's recommendation and say, start on day 5. And I might take Giovanna's recommendation and do recurrent events and then have something that would make regulatory. But I think with sacubitril valsartan, I'm very comfortable we showed safety in an acute population. And I'm very comfortable we showed trends for benefit every time we looked at it. And I'm very comfortable we showed less recurrent events. So I put it in your hands. You're not the regulators. I'm not a regulator. You're a physician. That's the beauty of it. Clinical trials give you information to make your decisions.
Giovanna, Mark loves getting questions from you. This is clear.
Okay. No, thank you. I have just a comment. As a physician involved in the treatment and management of patients with acute myocardial infarction and ST elevation acute myocardial infarction in particular, as I lead the team of STEMI at the Catholic University. What should I recommend to my colleagues if I have a patient that have a STEM, an ST elevation MI, and is not yet treated with any ACE inhibitor or ARBs? Yeah. Can I recommend to start with the ARNI directly or not?
Well, the first thing I would do to your team, since you're leading a team, is pat everyone on the back. This is a team that comes in round the clock. Please call me, no matter when. I want to be there to help this person having an ST elevation MI. I mean, isn't that amazing? And it's so amazing. It's all over the world. And that's why my last slide on the effect of time on overall mortality is just something. Now, Pardeep has been sitting on data about just that. What happens to people over time? Better, better, better. The infarct population, it's amazing. I just saw data that from my friends in Denmark, where they have registries and registries that talk to registries, know their every drug people get, and can do it every 2 years. And it's not just that from in the last 20 years that mortality, 1 year mortality is down. They have data to show it's down every 2 years. Every 2 years, better than the 2 years before, better than the 2 years before. So my message to your colleagues is thank you. Now, when you get down to now I've opened the artery. Now I've, by the way, this is somebody on a statin. I'm doing all those things, aspirin, antiplatelets, and now I want to inhibit the renin-angiotensin system. I think we've given you an alternative, and it's up to you. But I think no one should leave the hospital. You asked about the 36 hours. People should start immediately, and then it's a question. And if I was seeing that person in follow-up, I'd be aware of the Paradise MI data, and I would say, this is a factor. But I can't say we've proven it definitively that you read it in your guidelines. You must inhibit the renin-angiotensin system because you're helping people. You have many tools to do that. You asked about that 36 hours. It was a very important question. We asked that. Do it early. And then I think any hint of joining the heart failure club, this drug is superior to an ACE inhibitor in heart failure.
Filippo, did you spot any question from the chat?
Yes. I have a couple of questions. One is again what happens behind the scene. I have a question from Fabian Barbieri asking why you said initially it took a long time before we could start the trial dealing with the drug company. What changed their mind? Why the trial was delayed and eventually launched?
Well, I can't speak for them, but if I was, I would be saying thank you to them. This is a company, now this is Novartis, who they not only supported the trial, but they also share the data. So Pardeep knows this very well. It's not like some of these questions, you ask a question, we then have to go back to them and get the answer. The minute the trial, the data was sitting at the Brigham and Women's Hospital. So all these questions, everything you've seen is independent numbers from us with verification from them. So not only did they fund, but they share, not just the good news, but all news. So let me put that out that, you know, the general audience thinks that the pharma funds a trial, you will find these results or you will not hear about it. You can hear everything. And about being an editor, I'm asked, what does it mean to be a co-author on a paper? Well, not all authors have the Brigham and Women's database in their hands, but every co-author could ask a question. They could ask, what about those whose blood pressure dropped? And we answer. So wonderful. Now, why it took them so long? I don't know. They have other priorities, drugs and cancer. These trials are hundreds of millions of dollars. So we can ask, and the people we're asking in cardiovascular want to do it too. But somebody has to decide, am I putting a drug out for cancer that will certainly pay back? Am I putting a drug out for inflammatory bowel disease? So they're complex questions that I can't answer.
Thank you, Mark. And then I have a question from a colleague you know very well, who is Domenico Ramario from my group, who spent time in Boston. And of course, we come to microvascular obstruction.
Yes.
Microvascular dysfunction. So the question from Domenico is, what about this approach in patients with microvascular obstruction? We know that the outcome of patients with microvascular obstruction is much worse as compared to the others. In particular, the risk of heart failure is 5 times higher compared to those without. Any?
Yes, I have to think this is first of all, in the early days of remodeling, what were the factors? And MI size. And then when we got into MRIs and other ways, mechanistically, you could show it's not just reperfusion, but it's effective reperfusion. I'm very impressed with those studies in animals and the few studies in man. But yes, you want to leave the hospital with an open artery. You want to leave the hospital with an open artery that perfuses. We just don't have those measures easy enough. So then you get to a clinical trial. Mechanistic trials, clearly, yes, it's worse to have areas that aren't perfused. But then how do you translate that into a major outcome trial? The modality you need, the imaging you need to do in the midst of an acute MI are not something everybody can do. So Domenico's onto something very much that I'm very much in favor with, but how do you translate that to prove it? So maybe the message is after the dust settles, the infarct happened, I can now go to imaging and tell you how much of the myocardium isn't moving. I can go to further imaging, how much is not perfused. Take that group. If they already have heart failure, they shouldn't be randomized. They should already be on. But if they don't have heart failure, that would be a great study. Domenico, put your request in. That would be a great study. It would require a lot of cooperation. You know, that's the nice thing about trials. It would require working with people who could do that imaging. Not everybody can. And set your criteria, and then it's open for study. Excellent idea.
Well, but Mark, it can be really similar based on blush rate and ST resolution. That was shown by Bernard Gersh many years ago.
Yes.
Without ST resolution and impaired blush rate, the mortality was 10% versus 2% in the other group.
But yeah, but then everybody, okay, it gets to the imaging and blush. Please define blush in a way that I can now use it to build on a clinical trial. Yes, the TIMI reperfusions, sure, obviously. But I think Domenico was talking about not just blush, but non-perfused areas that I can quantitate with this black and draw a circle around it. Yes.
Yes, but there are similar measurements which correlate very well with microvascular obstruction and CMR. But
yes.
Domenico will send you the protocol in the next few days. Okay?
And the minute you go to simpler, the more gray I have.
Okay.
And if I have gray, your journal club's going to say, but what about this side? So that's the beauty of compromise in clinical trials.
Thank you, Mark.
Will you take another question from John Cleland?
Oh, well, since he gave me an easy one, he can't, he's having trouble. I can't see John Cleland, but now I can. John Cleland is having trouble that he gave me an easy one. So
he's back to universal definition. Please.
Now the question is about loop diuretics. He noted that patients with sacubitril valsartan do better in those patients taking loop diuretics as a sign of congestion. What do you think of this? Do you have a comment or?
I'm afraid to, because he has my numbers right in front of him and I'm not looking at my numbers, but I will say the entry criteria was you could have pulmonary congestion. As a matter of fact, we welcomed that, but you couldn't at the time of randomization. So you couldn't have an IV diuretic at the time of randomization, but that meant that they could have lived on a loop diuretic, and many did. And as a matter of fact, that subgroup is like all other subgroups, favored sacubitril valsartan, but not without a significant interaction. So if John is saying another way of giving, he asked about the sicker patients and he doesn't give up. So now he's asking another way to define sicker patients. But once again, I can't say those people got the benefit, meaning the others did not.
Let me put it in another way. How would you feel considering sacubitril valsartan for those patients with presenting also with high blood pressure at the time of myocardial infarction, which is not very common, of course, but it's or those who are intolerant to ACE inhibitors? Could this be two conditions in which the physicians could consider?
Yes. So Michele Sende is writing our paper about blood pressure. But you just said something very interesting, Maximo, and I know you love blood pressure too. There's something about the MI that we did genetically hypertensive rats, spine, SHR. You infarct their heart. Domenico, you infarct their heart, and their blood pressure drops precipitously. We didn't change their genes. We didn't touch their kidney. So there's a permissive role. And the bigger the scar damage, the greater the reduction. So your question had an answer in the question. You said we don't see it that often. The reason you don't see it that often in the big MI is just what I just said, that damage. So we will look at those with the higher pressure. Yes, the drug is more effective in lowering blood pressure. And conversely, if you say that, we had more people stop for hypotension.
Right.
So yes, so the yin yang, are we going to find the sweet spot? So it sounds from the questions, everybody'd like us to go back, learn from this trial, and hit the sweet spots, which I agree with, except to go back is $100 or $200 million.
There's another old friend of the blood pressure clan, Denise Clement. He's asking about, he's asking about the dosage of ARBs.
I thought he would ask about pulse pressure.
Yeah, the question is about the dosage that has been chosen for.
Yeah, well, obviously for sacubitril valsartan, we chose the dose used in Paradigm. Yeah. And we tried to get to that target. And Paradigm, by the way, was a much better study at dose because John McMurray was carefully making sure that the first criticism he'd have is you beat enalapril, but you didn't use enough enalapril. So, and that wasn't the case. So we were against ramipril, and we used the dose used in air, and more people got to that dose than got to the dose of sacubitril valsartan. But I think that's not a criticism, that's just real life. You would look at the results, people tried to titrate, here's the dose they got to.
That was great. Yeah, Pardeep and Giovanna, you have any further comment? We're approaching the end.
No,
I would like, please go ahead.
No, I was just going to say I've been sitting listening thoroughly and always learning, but I don't have anything just at the moment. Giovanna, please go ahead. You sound like
I was making the same comment. It was really a great pleasure to be here and to have this lesson from you. Really, I'm happy to be here, to have the possibility to ask you something. And actually, I'm pretty convinced that ARNI post-MI will do very well. So I'm one of your followers in this. Okay.
Well, thank you. And I want to thank you for bringing up the 36 hours, because we probably spent about 4 weeks working on that just to be able to answer your question. So thank you.
So Marc, thank you very much for being with us. But I'm about to leave the conclusions and maybe some final question to Filippo. But I personally, I've been a follower for more than 30 years of your work, and it's really amazing to be, with you today in a dialogue, and you giving such clear explanations, and you have such a clear vision of myocardial infarction and left ventricular dysfunction, and for every one of us it's been a wonderful hour. So Filippo, the podium is to you.
Thank you, Massimo. Well, very briefly, Marc, we all love you, sincerely. I had the last question. We published a viewpoint from Faiz Zanal about the underutilization of aldosterone antagonists in the Cinderella of treatments. This was the title. And he started from the paradise, noting that only 40% of patients were on aldosterone antagonists. Do you think that they're really underutilized, or perhaps in many patients we cannot use them?
I'm aware, obviously it's an important point. And I tried to say that we're treating on top of, which everybody can criticize, how come it was only 96% statin? Why didn't you, how come it, yes. So Fayez and Bert Pitt have almost single-handedly over the same period of time that we were talking about, moved mineralocorticoid inhibition to helping human beings from starting with heart failure, and they also did it post-MI. So there's an overlap there. The design of Ephesus and the design of Paradise aren't exactly 100%. And I think if we took his design and matched, we were in the high 60% that would really match the time period and the inclusion criteria and the ejection fraction. And then, of course, we looked at that subgroup. And yes, there's no interaction, which doesn't mean no effect, but it is important. And so rather than give you a number, I would say he's absolutely right. If somebody already qualified for a therapy, they should get that therapy. What we're showing with Paradise MI is we don't lose our effect on top of, which, Filippo, if I were to summarize cardiology, I would say that statement is a hallmark, that you would read table one. Table one, as a journal editor, you're going to say waste space. They were randomized. Of course, they're equal. But table one tells you how well those people were treated before the experimental. And table one in a cardiology manuscript of a cardiology trial is usually excellent. And I think we should continue that.
Thank you, Mark. It's almost 1 hour, fascinating hour. We are discussing Paradise MI with you, with Pardip, Massimo, and Giovanni. It's been really a fascinating hour. We are grateful to you. All the editorial board is grateful to you for dedicating your time to the European Heart Journal. And I'm sure we will have you here in other occasions in the future. Well, now let's just remind you that next dialogue, next Socratic dialogue, as I love to call them, will be, as usual, on the last Thursday of February, will be February 24th at 5 p.m. Central European Time. Thank you again, all of you. Bye-bye.
Thank you.
Bye.
Thank you.
Thank you, everyone, then, for joining. We'll just wait for everyone to sign off. And Mark, if you want to stay in the line for a few more moments, that would be fantastic.
Okay.
Thank you, everyone.
Many people thanking you, Mark. Well, it was really